Hello and welcome to this session on ethical cases for group discussion. You should review this video and then we will discuss these in our Wednesday afternoon midweek review sessions. I'm Professor Anthony Cummins and this video is put together by the Department of Family Medicine at RCSI Perdana. We have 4 cases to look at, so this is case 1. This is about professionalism. There are 2 learning outcomes here. The first one is that you should be able to explain what professional behavior is, and secondly, to outline the differences between personal standards and generally accepted standards of behavior. In this case, you are treating a Mrs. Jenny Lee, a patient who has long-standing COPD and osteoporosis. She is a long-term smoker. You have repeatedly over the years counseled her about the risks of smoking and also the benefits of quitting. She has steadfastly refused to attempt to quit. You now tell her that if she does not quit smoking in the near future, you will be unwilling to continue to treat her smoking-related medical conditions. The first question for you is this professional behavior? And the second one is your attitude towards professional issues in this case a personal standard and or one that is generally accepted? Let's look at the second case. This centers around the issue of confidentiality, and the learning outcomes of this one are the following. You should be able to explain what is meant by confidentiality, especially in the doctor-patient relationship setting. You should be able to identify when it is ethically licit or acceptable to disclose confidential patient information to a family member. You should be able to describe the elements of informed consent. You should be able to outline the criteria for assessing functional capacity for decision making. And you should be able to define the following: an adverse event or adverse incident, a suspected adverse event, a no harm event, or a near miss event. You should be able to appraise when to disclose information to patients regarding incidents that occurred which may impact, or have impacted on them during their care or treatment. Let's look at a case now centering on the issue of confidentiality. Mr. Srikumar Sharma is a 74-year-old married man who lives with his wife in Kuala Lumpur. He's been attending a GP clinic for many years. He was diagnosed with hypertension some years ago, and for this he regularly takes Ramipril 2.5 mg once daily, Bisoprolol 1.25 mg once daily, and furosemide 40 mg once daily. He hasn't suffered any adverse effects of these medications and is otherwise in good health. He has 2 children, a married daughter who is a busy criminal lawyer working in Singapore, and a son who works in Melbourne. Recently, he was admitted to a hospital, Kuala Lumpur, with a tachycardia, which later was diagnosed as atrial fibrillation. He was therefore started on warfarin and has his INR monitored weekly at your clinic. When he was having it done recently, he asked the nurse if he could get a new prescription as he'd run out of tablets. The nurse advised that usually the practice is that the clinic needs 24 hours notice for repeat prescriptions. But as it was urgent he'd run out of his medication, she felt it was prudent to get the GP registrar to write a prescription for the usual repeat medications. The GP registrar had not previously met Mr. Sharma, and this is her first year's posting in family medicine. She was quite busy that day, but she did write the prescription in between consultations as requested by the nurse. Mr. Sharma was given the prescription and then left the clinic. Approximately 3 weeks later, he phoned to make an appointment as he felt very unwell. He felt dizzy, and he'd noticed he'd been going to the toilet to pass urine a lot more frequently than normal. He was seen by the same GP registrar who had prescribed the medication. She checked a urine sample and this was clear. She also checked his blood pressure, which was 100/70. His heart rate was normal. She then took bloods for full blood count, renal profile and liver function test, and arranged a review appointment for him the next day with the results. She advised him to bring along his medications to that appointment. Before that visit, she checked the results and noted there was moderate renal impairment. She noted also that there had been no prior history of renal impairment. The full blood count and LFTs were reported as normal. On reviewing his medication list and recent prescriptions, she realized that she had prescribed furosemide 80 milligrams rather than 40 milligrams. She reckoned this was the most likely cause of his symptoms and his new renal impairment. He arrived for his appointment accompanied by his daughter, who had come from Singapore. Her mother had telephoned her to advise her that her father was unwell, so she left her husband to look after their young family. She was very concerned about her father's health, and particularly worried that he's getting forgetful. She wondered if he may have taken a double dose of his medication by mistake, and hence he was unwell with a urinary frequency, etc. She is also concerned that he's getting frail and that he falls easily. She also mentioned that her father has a few alcoholic drinks in his local pub with some old friends once a week, and maybe this might be affecting him given that he's on important medication like Ramipril, bisoprolol, furosemide, and now warfarin. Her mother was also anxious about him. His daughter, when she came with him, specifically wanted answers to the following questions. She mentioned these questions to the registrar in the presence of her father. Was it safe for her father to be on warfarin if he's at risk of falling? What side effects should he and their mother look out for? What if he starts bleeding? What should they do? Is it safe to have a few drinks at the weekend with this medication, and if so, how many? Wouldn't it be more accurate to have the blood test done in the hospital rather than at the GP clinic? And could her father not have some new tablets which do not need blood tests done? Since she can't come that often from Singapore due to family and work commitments, would the GP ring her every so often to let her know how her father was doing? Mr. Sharma was calm and silent as his daughter asked the GP registrar her questions, and when she had finished, they both waited expectantly for the GP registrar's reply. Now it's your turn to consider all of this and advise how the GP registrar should respond. How would you respond to these questions in this setting? Let's go on to case 3. This is a clinical scenario about a pregnancy termination request. The learning outcomes for this case are that you should outline the range of options that are available to resolve a crisis pregnancy ethically and legally in Malaysia. You should also be able to explain the constitutional position regarding the rights of the mother and the unborn in Malaysia, and explain the legislative provisions regarding the termination of pregnancy here in Malaysia. Your case concerns Jenny Lim, who is a 38-year-old single Hong Kong-born woman who moved to KL 2 years ago. She's been working there part-time as a receptionist in a 5-star hotel. She likes her work, but she struggles to make ends meet in her part-time salary. She's also due to have a rent rise soon, which is putting more pressure on her financially. She knows there's a full-time job coming up in the hotel within a few months, and she's keen to apply for this and hopes to get it. It certainly would give her financial and professional security. She has no family in Kuala Lumpur. Her parents still live in China. She's an only child. She has 2 close female Chinese friends whom she met since she came to Malaysia 2 years ago. About 2 months ago, she met a man at a function in the hotel whom she knew by sight. He lived in the same area where the hotel is with his wife and family. She'd had a number of drinks during that function, and she became quite intoxicated, though nobody seemed to notice. After her work shift finished, she went with the man to his room and slept with him. Neither of them used any protection. She subsequently missed 2 periods, but she assumed it was related to her lifestyle. Years before, when she had dieted to lose weight, her periods had stopped for a while and then resumed normally after a few months. However, when she missed her period the third time, she became worried and she went to her GP, where the practice nurse performed a pregnancy test, which was positive. She was quite shocked at the news and berated herself for acting irresponsibly by not insisting that the man used a condom. She knew that she had drunk too much at the function. In fact, she knew that she drank too much generally. She had previously been to the A&E department at Hospital Kuala Lumpur for abdominal pain, where they had told her that her liver was damaged from alcohol and she should abstain. She tended to drink alcohol most nights, usually almost a bottle of wine, although less if she was on the early morning shift at the hotel. Her usual intake was approximately 60 units per week, about 3 to 4 times over the recommended maximum. And this had not been the first time that she had acted irresponsibly while drinking. She had received a driving ban not long after arriving in Malaysia, when she was caught over the limit. She had thought of stopping alcohol in the past, or at least of reducing her intake, but was willing to take help if it was offered, though she didn't seek help because she liked the buzz that she got from alcohol and felt it made social events more enjoyable. Neither the practice nurse nor the GP was familiar with any of these facts, which she kept to herself. The practice nurse suggested she see the GP to discuss the pregnancy test and its implications, and she agreed. She outlined the situation to the GP, but omitted the details about the excess drinking. And she explained that she felt it was impossible for her to have a baby on her own from the emotional, practical, and financial perspectives. As she had no interest in meeting the man again, she didn't intend contacting him to tell him that she was pregnant. Also, she had never really seen herself as a mother, and just wouldn't know where to begin to cope with the child, so termination was probably the best thing to do. So how should the GP deal with this request for a termination of pregnancy? How would you deal with this? What does the law advise in Malaysia? What are the ethical aspects of dealing with this request? Let's look at case 4. In this case, you should be able to explain why trust is essential in the doctor-patient relationship. You should be able to appraise the responsibilities of a patient within that relationship, and also appraise the obligations of a doctor regarding confidentiality. You should also be able to outline the circumstances when it is ethically licit or legal or proper or acceptable to disclose confidential patient information without consent. And you should finally be able to identify the ethical and legal obligations of a doctor regarding the notification of sexually transmitted diseases. Your patient here is Rachel, who is a 28-year-old mature student of physiotherapy, who has lived with her current boyfriend, a solicitor, for 2 years. Their relationship has its ups and downs, but generally is strong, and they have talked about marriage and children, but have not as yet got engaged or made plans to get married and start a family. Rachel is a social smoker and drinks also only socially. She's always been in good health and has been with the same GP for the previous 10 years. She has a good relationship with the doctor, but she sees him seldom, usually only every 6 months, for checkups for her oral contraceptive pill. She has no other significant medical history except for mild asthma, but only needs to use a reliever or inhaler occasionally. A month ago, she attended a GP. She'd been passing urine frequently for about 2 weeks. She had no dysuria or hematuria. GP performed a urine dipstick which showed leukocytes. A diagnosis of UTI was made and she was started on a 3-day course of trimethoprim. However, he did not send the midstream urine to the laboratory. Rachel went on to the chemist, got a prescription filled and started the antibiotic course later that day and completed the full 3 days. She continued, however, to feel unwell and developed also some vaginal discharge in addition. She made another appointment to see a different GP in the practice, who in consultation asked her about her sexual history. Rachel told him that she'd had unprotected sexual intercourse approximately 2 months ago. The GP performed a pregnancy test which was negative, a vaginal examination with her consent and also took some vaginal swabs. He started her on a treatment for a presumptive diagnosis of chlamydia, and when the official swab result confirmed the diagnosis 2 weeks later, he phoned her, advising her to make an appointment with her own GP to talk about the diagnosis. He also mentioned contact tracing. He sent a message to Rachel's own GP on the in-house GP software messaging system, telling him that Rachel had attended him recently and that STI swabs had confirmed a diagnosis of chlamydia. He also informed the GP that he advised Rachel to make an appointment with him and to discuss the matter further. When Rachel got the phone call advising her of the diagnosis of chlamydia, she was really shocked. She thought that this should have been picked up by her own GP when she had attended initially with the problem of frequent urination. She had also read on the internet that delay in diagnosing chlamydia could prevent someone from getting pregnant later on. She was now very worried about this affecting her chances of having a baby in the future. She also had concerns about the phrase contact tracing. She didn't want anyone to know that she slept with an ex-boyfriend after a party a few months previously, least of all her current boyfriend, with whom she hoped to marry. And if he had found out that she had cheated on him, she was sure that it would have devastating consequences for their relationship. She was also concerned that the GP would judge her as someone who was a cheat in her personal relationships. She decided that if the GP mentioned that her treatment for chlamydia would affect her boyfriend, so that he would need treatment too, then she would tell her boyfriend that the treatment was for thrush, and that way everything would work out and no one would know about her infidelity. So she made an appointment to see her usual GP to discuss the diagnosis of chlamydia as well as the treatment for it. Your question is, how should the GP deal with Rachel when she attends for her appointment? How would you deal with her? What are the ethical issues that arise in this case? Thank you.